Hello, and welcome to MycoClinics. My name is Nilesh Govender, and I'm based in Johannesburg, South Africa, at the National Institute for Communicable Diseases, and I'm also an honorary professor at the University of Exeter. So this MycoClinics session on the 2nd of September is focused on cryptococcosis. We've invited clinical experts to present 2 case studies with diagnostic considerations, treatment deliberations, follow-up and outcomes, concluding with a discussion and literature review. You as the audience will have the opportunity to submit your questions through the Q&A, which will be seen by the moderators only. And we ask that you don't submit your questions through the chat, please. Recordings of all our MycoClinics webinars, as well as Myco Talks and the Medical Mycology Trainee Seminar Series are available to view on the YouTube channel. The organizing committee for MycoClinics is listed here with representation from all global regions, and MycoClinics is supported and funded by the MRC Center for Medical Mycology at the University of Exeter. I'd like to introduce my co-chair, Professor Adelia Warris, who's a pediatric infectious disease specialist based at the University of Exeter. And today we have 3 experts joining us to present 2 cases, and we will introduce them shortly. So just to highlight that MycoClinics are held on the first Friday of every 3 months at 4 p.m. British Standard Time. The next session is scheduled for the 2nd of December and will be chaired by Arnaldo Colombo and William Hope. So we're going to go directly into our first talk. And I'd like to introduce Dr. Peter Williamson. Dr. Williamson is an ID physician and researcher who currently heads the Translational Mycology section at the NIH in the US, in the Laboratory of Clinical Immunology and Microbiology. His section currently studies genetic susceptibility to and clinical sequelae of fungal infections in patients, and they utilize a number of cutting-edge methods to understand and treat these important human diseases. Peter's going to be talking about the host matters, what we never knew about cryptococcal infections. Peter, I'm going to stop sharing and over to you.
Hello, can everyone see my screen? So good morning, good afternoon, and good evening, depending on where you're from. Welcome from America here for this talk. We're going to talk about some emerging data for a not so emerging pathogen at this point. So this is a, oops, we're not going forward. Oh, there we go. So I don't have to know in this audience, we don't have to go too much about the underlying disease of Cryptococcus, just to really, since I'm going to be talking about non-HIV, Dr. Jarvis is going to be talking about an HIV case. And so I wanted to show here, just while the HIV cases in the United States has declined quite a bit, the HIV negative cases from solid organ transplants, those getting steroids, even hepatitis, as well as GM-CSF autoantibody that I'll talk to you about a little bit better later, and idiopathic CD4 lymphopenia. These are quite persistent. And actually, if we look at the cases of other meningitis, we see that because of the vaccines, we've had declines in those cases in most of the developed world. But because Cryptococcus has stayed that way, it's actually the most common cause of non-viral meningitis in the United States today. So let's get to our case. So this is one of our most difficult patients. But it's a challenging group, so we'll try it and see if we can try some different paradigms here. Patient was a 43-year-old HIV negative, previously healthy individual, not on any immunosuppressants at all. Presented with nausea, vomiting, and headaches, diagnosed based on a positive CSF Indy Inc. And the cultures were positive for Gaudiae, Cryptococcus Gaudiae by Malditov. Patient was somnolent with papilledema on exam. Opening pressure was elevated at 55 centimeters. He was treated pretty standardly with liposomal amphotericin and flucytosine and had negative CSF cultures at 1 week, and then was changed to fluconazole 800 milligram daily due to acute injury at 4 weeks, because in non-HIV, you're supposed to treat 4 to 6 weeks. But his cultures were negative, so this is fine. Patient's intracranial pressures, however, remained elevated and required a VP shunt for communicating hydrocephalus with pressures over 40, but remained somnolent despite pressures normalizing. His CSF cultures remained negative. His immunologic workup was normal. His CD4 count was 600, normal CD8s, B cells, complement levels, quantitative immunoglobulins levels, all normal. And below, I show some of the CSF parameters here. I also converted to SI units, since the United States still has this weird, well, we inherited from the British, but we kind of stayed on with this. So we use this weird milligram per deciliter. So I've converted it to millimolar as well. And you can see the CSF glucoses are remaining a little on the low side. The opening pressure after shunting is a little bit going to be a little bit down from here, but it's still a bit elevated. His cryptococcal antigens are positive, but his cultures became negative after about 1 week, actually, which is a pretty good response. So the question is, what do you do now? Patient's not doing well, but you've done what you can do. So what do you do now? I think there's a question machine or something like that here. There we go. What should we do now? Should we give another course of amphotericin B? Should we add flucytosine? Should we add recombinant interferon gamma? Or should we do something else? Do we see the answers or no? Ah, okay. Something else. Well, I'm glad everybody has an open attitude to this. So a lot of people would give amphotericin B or try to intensify antifungal therapy. We're ID people, we like to kill things. And gamma interferon sounds reasonable because, we have to kill that fungus, and it is part of the IDSA recommendations. Or something else, let's try that. So what do we do? Just going through the list. So here we go again, and this is an MRI that we got at the same time, and you can see this cryptococcoma in the right parietal cerebral area that's enhancing. You can see there's the choroids were also enhancing. This was causing the communicating hydrocephalus that he had. And so we recommended, because the cultures were negative, this was done at an outside hospital, to get soluble cytokines, which you can get commercially, actually, at least here in the United States. And we've been able to corroborate these quite well. And you can see elevated levels of IL-6, IL-8, and soluble 24, which is a good marker of T cell activation. Anybody who's worked on HLH, these various macrophage activation syndromes, have ordered these same cytokines. And when they're elevated, it suggests you've got an inflammatory process, but the cultures are negative. So we went ahead and we gave what we've been doing, which is giving solumedrol, large doses, 1 gram daily, corticosteroid pulse therapy, really takes 7 days, and then prednisone 60 milligrams daily. You can see here that the inflammation has really, in the second set of MRIs, has really disappeared, and the choroiditis is improving. Patient really woke up, the headaches resolved, his mental status improved, and he was discharged on prednisone 80 milligrams daily, which is 1 milligram per day. But then most of our patients kind of do well from here, and we taper them down, as I've published. But this patient was more difficult than most of ours. He had multiple ER visits with intractable headaches, and they put him back on prednisone. They didn't always talk to us. And so this guy was on prednisone, and after finally with COVID dying down, we were able to bring him back in 7 months. And we figured, oh my, they're over-treating this guy. We should be able to taper him down. He's now 7 months out. And so we saw him at the time here at NIH, finally. Normally we bring them in within a day or two, but in this particular case, we didn't really get him for 7 months. And so he came in with these intractable headaches, poor memory on prednisone of 70. And we thought we were going to able to, that they were just overreacting. But what we found was he actually had 200 white cells in his CSF, despite all that prednisone. And he had an IL-6 level now that was much higher, a 300, and a soluble CD24, which was up, suggesting inflammation. Now, one of the things that we're able to do here at the NIH is we're able to do flow cytometry on the cerebral spinal fluid. Oh, by the way, here at the MRI, you can see that he's now developed an area of inflammation, leptomeningeal enhancement here, as well as in the internal capsule as well. We get an enhanced flare, so basically a post-contrast flare for MRI is really, really good, and I would encourage anybody looking for inflammatory process to get an enhanced flare, post-contrast flare, and you can really see the inflammation. It's very difficult to see on like a T1 plus contrast kind of a thing. On our flow cytometry, we use HLA-DR4 as an activation marker, and you can see if the CD4s and the CD8s are still quite activated, about 5,000 activated CD4s per milliliter. Usually when anything over 200 is where people begin to deteriorate. So this is a pretty elevated amount of inflammation. Cultures are still negative at this time, but he's on the high doses of prednisone. So what we actually did is, this is one of our first patients that we added tocilizumab monthly, 8 milligrams per kilogram per day, and that brought down his counts a little bit. Finally ended up we started him on ruxolitinib, a JAK inhibitor, which I will talk to you about soon. His headaches resolved at that point. He went camping for the first time. He felt great. You can see here on the enhanced flare, everything has disappeared. His headaches resolved. The internal capsule lesions have resolved. He went camping. He was able to go back to his normal life, and we were able to finally cut down his prednisone to 20 milligrams daily, and I think he's off by now. And his IL-6 levels went down to 3 milligrams per kilogram, picograms per ml. Everything's settling down. We did also a number of immune workup. The CD4 is again normal, his immunoglobulins were normal, complements were normal, had a normal response to mitogens and vaccines. But we found he had an autoantibody to granulocyte monocytic colony stimulating factor, which I'll get into soon, is a big risk factor for Cryptococcus gattii, which this patient had. So what is all this that we did? And let's go back to some of the basic science. And I think this is an example where some basic science can really help us to understand pathophysiology, and then we can design our treatments based on what we know. So a couple of quick things about Cryptococcus. One thing we all know, it makes this capsule. We've seen these Indie inks, and the capsule is this big fluffy thing, which then another enzyme, a lactonohydrolase, acts on it, and it makes it kind of like paint that's been sitting in your basement for about a year, the old paints anyway, and they compress down. You can't stir them up because they're very hydrophobic and they just pack down on each other. And that's what the capsule does of Cryptococcus. And so you can see it here on EM pictures. Without this lactonohydrolase, it's big and fluffy, and the wild type packs it down. And it doesn't, here's complement deposition, and you can see in the mutant, complement binds to it really well, but the wild type, and if you add this enzyme back, complement antibody doesn't bind. And this is one of the reasons why Cryptococcus is a good pathogen. It's just not recognized by the immune system, okay? But inside is where all the antigens are. Where the cell wall is where all the antigens are. The capsule surrounds all this and keeps the immune system from recognizing it. The second thing to remember is that Cryptococcus, unlike most pathogens, even after you kill them, they stay for a long time. Here's a good example. Here's a 44-year-old who died of an unrelated cause. He had a T-cell lymphoma, he had HLH, but he had recovered, and he died because of that. But he had recovered from cryptococcal meningitis about 8 years prior, and he was off antifungals, his cultures are negative, and this is from his autopsy. And his autopsy did not grow crypto. But this is the Virchow-Robin channel sort of penetrating here, the vessel in the middle. And you can see all these beautiful cryptococcal organisms that are still there. And they have the potential to stimulate the immune system. Here's a mucicarmine, which is very specific for Cryptococcus. And you can just see they just look beautiful. So unlike parasites or a lot of bacteria that just kind of disappear, these things stay for a long time, and they can continue to stimulate the immune response. And this is why it takes so long to get these under control. And so in order to be able to look at these, we started looking at some of these most severe cases, because as you know, about 30%, up to 30% of these patients the transplants, the non-HIV, the previously healthy people still have about a 30% mortality. And so why is that? You know, our antifungals, the cultures are turning negative and the patient's still dying. Now there are comorbidities as well, but a lot of them herniate and develop an increase in intracranial pressure and dying. So we want to really focus on these. So we have a protocol. We've recruited about 150 patients now, so we have quite a bit of experience. And we routinely fly these people in by air ambulance to the clinical center here. And they come in by jet all the time. And they're all obtunded and they go to the ICU and they do. And so what we're able to do at the clinical center is our lab is just next door to the hospital. So we can run our CSF down and we can do this extensive flow cytometry very easily. And when we did that, we found that, you know, unlike the HIV cases where your immune system is really down and your CD4 count is really low, these patients really had quite an inflammatory process going on in the CSF. So in the blood, not much. You don't see anything in the blood. That's why their CRPs are normal. You don't see anything. You have to go to the CSF. Their HLA-DR4 positivity, the CD4, CD8s, the inflammatory NKs, the monocytes are all up. There's just a party going on. And what's happening is the Cryptococcus is broken. Amphotericin is a cidal drug. It releases all this protein that's inside the cell. And then suddenly you have an immune system which just kicks in and is now detecting all these antigens and just goes crazy. And so without any real immune reconstitution that you get with HIV, you get this tremendous immune response that happens. And when you look at gamma interferon levels, you see here, they're off the wall in the CNS patients compared to pulmonary cases or healthy volunteers, just really high levels of gamma interferon. The downstream genes like CXCL10, which are gamma interferon responsive, are up. IL-6 is up. IL-18, which is recruiting other cells and neutrophils, and is also up as well. And so you go back to those IDSA recommendations, and the recommendations still are that refractory disease in non-HIV conditions, the basis is the paradigm of HIV without the pathogen. They assume that adjuvant immunotherapy with recombinant interferon could be considered for refractory infection with the common use of a specific antifungal drug. Now you do this and you have huge gamma interferon levels, you're going to pump more gamma interferon levels. It's like putting gasoline on the fire, right? And so it doesn't really make sense. And in all our patients, you can see this kind of inflammatory response. And it's in the patients who are doing badly, you'll see this tremendous inflammatory response. So let's go back on this again. So here's a little simplified idea about what's going on in the brain. Dendritic cells are recognizing cryptococcal antigens, signaling T cells, which are really, really important, and produce TNF alpha and gamma interferon. And then your macrophages produce INOS and other common cytokines and molecules, signaling molecules, and they produce large levels of TNF alpha. This would be the appropriate response. And the reason is, so just looking at our patients, we saw the T cell compartment was really activated in these patients who are not doing well. And looking at CD68 as a marker of monocytes, you can see there's a tremendous monocyte infiltration. This is from an autopsy that was done. We also, here's a biopsy of one of our patients. And you see that INOS, unlike the activated T cells, the macrophage activation is not really going on so much. Whereas the alternatively activated marker CD200R1 is activated. So these macrophages are really not responding the way they did, and probably because of the genetic defects that we found in a number of these patients. And if you look at the functionality of these in situ, if you stain the calcifluor, Cryptococcus with calcifluor, you can see that the macrophages and the fungus is just not lining up. It's like these monocytes are just kind of sitting on the beach, kind of having a good time and really not doing anything. And this is why they got crypto in the first place. And that's a really big focus of some of our genetic studies. And the reason is because of this GM-CSF autoantibody. But the thing about the GM-CSF autoantibody, it's really specific for the fungus. So once you break open that organism, you're basically have a normal immune response because they react to these kind of antigens fairly normally and they get this big response. So kind of like IRIS with HIV, where you get immune reconstitution, we named it Pierce. post-infectious inflammatory response syndrome, where you get the same kind of activation, except you have alternatively activated macrophages. So most of the heavy damage is because of the T cell cytokines that are produced. The interesting thing, because of the macrophage lack of activation, you don't produce much TNF alpha, and which is the major cytokine that induces fevers. And so in the non-HIV patients, only 5% get fevers. And that's one of the reasons why these patients do not get diagnosed. Our record is a patient who went 24 months. His wife had divorced him because you're lying on the couch all the time. And he'd come in and they'd kind of ignore it and whatever. He was admitted to a psych hospital. And after 24 months, they finally did a lumbar puncture. And, oh, you've got fungus growing in your brain. That's why you're depressed all the time. So after we treated him, he's fine. And he's like running a 5K and back to work and everything. So very important with the TNF alpha. So it's not enough to just define a new syndrome. Now we have to figure out how to treat it. And it's petrifying, as an ID doc, to use steroids on these patients, because steroids are a known risk factor for Cryptococcus in the absence of antifungals. But once you kill the fungus, much, much better. And amphotericin is actually a pretty potent drug. So we define this post-infectious inflammatory response syndrome as an unchanged or declining mental status. We use MoCA, which is the Montreal Cognition Assessment Tool, which is that thing where you draw clocks and everything. It takes about 3 minutes to do. We found a MoCA less than 22 out of 30 correlated with a poor outcome in our 25-center CINCH trial. So if they have a declining mental status, certainly if they're not waking up, they're not going to draw a clock. That's pretty obvious. They had visual deficits, not refractory in nature, or a change in hearing. And our one or more supportive criteria have been increased CSF white count, protein, decreased CSF glucose in the setting of negative fungal cultures. Increased inflammatory markers, if you can get them, and in the US, it's pretty easy to get these now. Elevation in CSF activation immune cells, if you've got access to flow cytometry. And the brain MRI is really fantastic. And the post-contrast flare is really good, especially when you have small areas of inflammation that might be out of that might really be causing an anatomic defect. We had a patient with a hippocampal lesion and not a lot of inflammation, but it was all centered on the hippocampus, and she couldn't remember anything. She didn't remember her LP that she had that morning and couldn't function because of that. So we had 15 patients, healthy patients. This was published a little while ago in Clinical Infectious Diseases. And 15 patients will be followed. They were admitted, and they were treated in a very uniform regimen with hepatitis serologies, quantiferons beforehand. And we treated with liposomal amphotericin and solumedrol daily, followed by a prednisone, which we tapered over about a year. It takes really a long time because those antigens just stay there. And what we found was that most of these patients were males. It took a long time to make the diagnosis, as we've shown, and a number of neoformans and Gautii. A number of patients have been shunted before they got into us. Didn't seem like it made much of a difference. And you can see here, headache was a predominant symptom, altered mental status, which actually worsened during therapy. And that's that. And it takes a couple of weeks for that inflammatory response to kick in. And so you actually get worse with time after antifungal therapy. And you can see here that MoCA study that we did, everybody pretty much improves. This is kind of like the little kid that comes in with a brain tumor and edema, and you treat them with corticosteroids and they wake up in 3 days. The thing is, with us, we have a benign disease, so it's very easy to treat and you can kill it. You know what I mean? Tumors, so it's really nice. So the MoCA score improves, the Karnofsky score improves, opening pressures come down. We were able to avoid shunting in about half patients with elevated pressures. Sometimes they rebound afterwards and we have to shunt them. Papilledema measured by retinal nerve fiber layer came down, visual fields improved, pretty good response. The inflammatory parameters, you can imagine, the CSF glucose improved, the cell count came down, the protein came down, although that can often take a little bit longer to do. Looking at soluble markers, if you look at the blue is the CD8 cells, the purple is the CD4 cells, and the HLA-DR4 is across this x-axis, and you can see all these inflammatory cells, and then after treating, you can see how that disappears. It really just makes the inflammation melt away. You also get an effect with cerebral edema, which is sort of a double hit. which is really nice. So you can see the activated CD4s come down. The monocytes in the CSF also come down quite a bit. The soluble IL-6 comes down about 10-fold. Everything comes down about 10-fold. And the T-cell markers come down about 10-fold. Looking at the MRI, here's a particularly bad MRI, which you can see all this post-flare, post-contrast flare imaging with vascular involvement, choroiditis. This patient was just horrible. And post-steroids, you can see how it all melts away. We did an MRI score criteria to kind of quantitate this, consisting of meningeal enhancement, parenchymal lesions, hydrocephalus, transepithelial flow, basal ganglia lesions, and you can see all these are improving at that time. Neurofilament light chain is a nice marker of axonal damage, so we use that. This is just to show these patients continue to get improved. It's not just some temporary thing and then they go back into a coma. As they go through their taper, they're able to go back to work and do pretty well. And neurofilament light chain, which takes a long time to come down, it takes months in multiple sclerosis and other diseases where you have an effective therapy. It just takes a long time to respond, but you can see it continues to improve with time. With steroids, you can get side effects, certainly, although we got less than we thought because I think we're tapering them down quickly. Some osteopenia, one person had to be on bisphosphonates. We had some cataracts, but these are older patients as well. And then some ocular hypertension was treated with drops. So here's, it's easy to see all this data and you don't see this and you just wonder. So here's a typical patient. This isn't like our best patient. This is like a typical patient. 59-year-old, previously healthy, diagnosed with crypto, treated with AMPHO, culture negative at 2 weeks, deteriorating mental status. He was actually going to go to refer to hospice care, and that's when they referred to him. And this is his wife trying to get him to respond. And this is how he came in by air ambulance, going to our ICU. This is his wife.
Can you talk to me?
I asked you what they do.
Can you talk to me?
Okay, so that's the way he came in after therapy. All his cultures are negative. This is him after 10 days, standing up, talking. He's got a little facial droop, but walking around. 3 months, he actually won the bass fishing contest. He hadn't been bass fishing in a year, and he actually won the contest. The stuff on his head is for the sun. It has nothing to do with Cryptococcus. But he was able to go back and live a pretty normal life. So that's really kind of nice. And so in summary, in 1956 is when amphotericin came along and was able to decrease mortality from 100% to about 30%, where it's kind of stayed in the non-HIV patients, especially the non-transplant patients. And now we rarely see anybody die, really. We had one patient with a pulmonary embolism that died like 6 months later. But really, there's a pretty nice response, except for comorbidities that the patients might have in the transplants. And so doing well. So our hardest question we had was from our scientific director, John Gallen, where he said, how come it took you 60 years to figure this out? And I think the reason that we couldn't find this before is because we didn't have the tools to be able to do cerebral spinal fluid and to be able to bring people to the NIH to really focus them down. So we really asked people to agree to send your patients into us, because then we can collate this experience. And I know you're very good medical care, there's no question there, but when you have someone where you can collate all these results and get them out, it makes things a lot better. So going forward, we have a couple of things. One of the things for Pierce we want to do is to look at steroid sparing activity. Can we be, our expectations now that people live and are able to do pretty well is, can we even raise their neurocognitive functioning even more? With this particular patient, he was really hard to control. And the GM-CSF patients seem to be more inflammatory, and so they're a little bit more difficult to control with just steroids. And being out, almost a year and still being on those high doses of steroids, you don't want that. And so tocilizumab, we kind of used a little bit. This is the IL-6 signaling pathway, and you can see it signals a lot of inflammatory responses. And so tocilizumab can directly hit IL-6, and most of the inflammation happens peripherally, and then the cells track into the brain. So even though tocilizumab doesn't get into the brain, it prevents activation, and you reduce cells a little bit, but it's kind of difficult because you have to give an infusion all the time. So ruxolitinib is a nice pill. And so when you do that, we kept the patients, we've treated about 3-4 patients at this point. We keep them on the same dose of prednisone, and we just do a month apart, pre and post. And you can see the inflammatory response decreases quite nicely. And you can see here the CD4 activation goes down. In mice, we can not have to use steroids, so we can remove that aspect, and we can see ruxolitinib is really nice at getting that cell count down. And the brain weight decreases as well, so we can decrease cerebral edema as well. And so we're going to try now a randomized study where we're going to randomize people to ruxolitinib versus nothing as well. A little bit about the GM-CSF to kind of finish this up, because this patient had GM-CSF autoantibody. So what is all that about? So GM-CSF is granulocyte monocyte stimulating factor, and it occurs in about half, we found, of the Cryptococcus gaudii patients. There's been a bit of an outbreak up in Vancouver Island and Northwest with a number of cases of Cryptococcus gaudii, and we find about 5/8 of them have an autoantibody to this GM-CSF. So what the heck does this do? So it actually acts as a danger signal. The best way to describe a danger signal is, imagine if you're out in a nice country field and it's 2 o'clock in the afternoon and you hear a bang, you'll say, oh, that's just a backfire. But if it happened in the middle of the inner city and it's 2 in the morning and you hear that same bang, you probably duck under a car or kind of try to figure out where it's coming from. That danger signal gives you that situation awareness that allows you to interpret a signal. So GM-CSF does that. And what you do is basically along here, using IL-1 beta over here on the right, and if you titrate LPS, you can see the IL-1 beta increases. What GM-CSF does is it potentiates that at low levels of LPS. So the patients with the GM-CSF autoantibody, when they have tons of LPS around, like a bacterial infection, they have no problem. And they don't have problems with bacterial infections. But when you have Cryptococcus gaudii, what happens is, here's Cryptococcus neoformans, and here's again the IL-1 beta output. You see whether you add GM-CSF or not, that's fine, it signals okay, and that's why they don't get neoformans. But gaudii does not signal well with that. Again, both of them have capsule, but the gaudii is even worse, and you don't get that signaling. And with the GM-CSF, it potentiates that signal. And that's really critical, and that's one of the reasons why these patients get Cryptococcus gaudii. So I'd like to thank a lot of people in our lab. I don't think we have the time to go through everyone, but Dr. Anjum is our new staff clinician, is doing a lot of the clinical work, and Jessica Hartgarden is our PhD, who's been doing a lot of the flow, along with Kenneth Sesbambulade, I'm getting better at pronouncing his name, has been doing a lot of the flow with us, as well as our key nurse practitioner, Terry Scott, and a number of other people, collaborators, our neurology, imaging has just been terrific, neurocognitive testing, the audiology people has been really, really terrific. So I'd like to thank everybody and see if there's any more questions.
Thank you so much, Peter, for a great talk, and very interesting to see how cryptococcal meningitis presents and behaves in non-HIV patients. I'm sure we will have time later on for discussion. It's a pleasure to introduce the next two speakers. Joe Jarvis is a professor at the London School of Hygiene and Tropical Medicine and research associate at the Botswana-Harvard AIDS Institute Partnership. He is chief investigator for the Ambition trial, a multi-center phase 3 trial investigating novel treatments for HIV-associated cryptococcal meningitis. And he currently holds an NIHR research professorship based around translational research to further reduce mortality from CNS infections in Africa. And Dr. Melanie Alufandika works at the Malawi Liverpool Wellcome Trust Clinical Research Program, and she is a lead study physician and coordinator of the Ambition trial in Blantyre. And they will present to us cryptococcosis in people living with HIV, case presentation and evidence summary. So over to you, Melanie and Joe.
Great, thank you very much. Let me just share the screen. So hopefully you can all see the slides now. Great, so we're going to start with a case from Melanie, and then I will do about 10 minutes of discussion leading on from the case. So over to you, Melanie, to start.
Thank you, Joe and Adelia. As introduced, I'm Melanie Alufandika-Moyo. I'm a specialist physician and research physician at the Malawi Liverpool Wellcome Trust and Kamuzu University of Health Sciences. I was the lead physician on the Ambition trial, at the Blantyre site, and I currently lead the Share CM project at this site. Share CM is a project looking at facilitating uptake and implementation of the single high dose regimen for treatment of HIV-associated cryptococcal meningitis. Next slide. So I'll take you through the clinical case. I'm presenting a 41-year-old man who had been living with HIV for 3 years when we saw him. He was on tenofovir and amividine and efavirenz for 2 years before switching to a dolutegravir-based regimen about a month prior to presenting to hospital. He admitted to not taking his ART consistently. He didn't have a recent CD4 count or viral load despite being treated for disseminated TB and severe anemia a year prior to this presentation. Next slide. So on this admission, he complained of 2 weeks of headache, vomiting, and dizziness without fever or neck stiffness. He had not experienced any seizures. He did have unintentional weight loss, but there were no other symptoms. Next slide. In addition to the ART, he was on cotrimoxazole prophylaxis. He did not have any known drug allergies. Next. When we saw him, he was of poor nutritional status, but his Glasgow Coma score was 15/15. His general examination was unremarkable. He did not have oral thrush or oral Kaposi sarcoma lesions. He did not have features of dehydration, and his vital signs were normal. His respiratory, cardiovascular, and gastrointestinal system examination was unremarkable. And on his neuro exam, he had no focal motor or sensory deficits. Next. So in summary, this is a 41-year-old man on ART for 2 years with suboptimal adherence to his ART, presenting with 2 weeks of headache and vomiting after recently switching to a dolutegravir-based regimen. On examination, he has no significant findings. What is your top differential diagnosis at this point? All right, the poll can be stopped. So 70% of you think this could be cryptococcal meningitis, and followed by TB meningitis or meningococcal meningitis. So I agree with those. In our setting, the most likely diagnoses are meningitis caused by Cryptococcus neoformans, Mycobacterium tuberculosis, or Streptococcus pneumoniae. We also considered a space-occupying lesion in this patient. And considering that he had just been switched to a dolutegravir-based regimen, could this be an unmasking iris? Next. So these were the investigations that we requested for him. And I'll go through the results in the next slide. So at the lumbar puncture, his CSF opening pressure was not raised. It was only 5 centimeters of water. His full blood count was normal. He had normal electrolytes, and his renal function was borderline with a creatinine of 104 micromoles per liter, probably from the vomiting. His malaria rapid diagnostic test was negative. His CD4 count confirmed severe immune suppression at a level of 40 cells per microliter. But surprisingly, his viral load was suppressed with less than 50 copies per mil, and this could be due to the rapid viral suppression caused by dolutegravir following ART initiation. His TB diagnostics were negative. Next. So well done to those of you who thought he had cryptococcal meningitis. Well, obviously, this is a cryptococcal meningitis session, but his CSF results confirmed the diagnosis with a positive India Inc. and cryptococcal antigen test. He had a high fungal burden at 950,000 colony-forming units per mil. What induction treatment would you prescribe for this patient, considering that he is living with HIV? You have a few moments to choose your preferred antifungal regimen for induction therapy. All right, so the majority would give a start dose of liposomal amphotericin combined with flucytosine and fluconazole for 14 days. So it looks like a lot of us are up to date with the WHO guidelines. Okay. Next. So this patient was fortunate to present to hospital when we were running the Ambition trial. And Professor George Jarvis will speak more about this trial and the recent evidence after this case. So this patient was randomized to the control arm, and he was given amphotericin B and flucytosine for 7 days, followed by fluconazole 1,200 milligrams once a day for 7 days. As with standard practice, when treating patients with an amphotericin B-based regimen, we prehydrated this patient with a liter of normal saline, in which we added 20 millimoles of potassium chloride prior to each infusion of amphotericin B. We also supplemented potassium and magnesium orally and managed his pain with paracetamol and tramadol. Next. However, despite antifungal treatment and normal CSF pressures, the patient continued to experience severe headache, vomiting, and vertigo. At day 11, he had raised CSF opening pressures, but these had resolved by day 13 following daily therapeutic lumbar punctures. And his day 14 CSF confirmed good fungal clearance with no growth from his CSF. He had a normal fundoscopy and he didn't have orthostatic hypotension. And 1 week later, he was still symptomatic, and this prompted a brain MRI, which I'll show you on the next slide. So you can see that his cerebellum was normal. With the vertigo, we thought he could have had a cerebellar lesion, but it was normal. Next. However, at the level of the basal ganglia, you can see that there are bilateral symmetrical hyperintensities. And just at once, next. On this slide, you can just about begin to see that they are small, round, clustered hyperintensities in both basal ganglia. And this is a characteristic appearance of dilated Verco-Robin or perivascular spaces. And this is common with cryptococcal meningitis. Next. The radiologist confirmed the abnormalities in the basal ganglia and thought these were likely due to a fungal infection. How would you manage this patient at this point? Would you restart induction phase therapy, continue consolidation phase therapy, or add corticosteroids? All right. So the majority would add corticosteroids, and only 15% said to continue consolidation phase antifungal therapy. So this would be a reasonable option. Adding corticosteroids would be a reasonable option in an HIV negative patient, as has been presented earlier. But in patients living with HIV, the management is a little different, and I'll show you in the next slide. However, when we looked at the literature, in a series of 87 patients with HIV-associated cryptococcal meningitis, 66% had abnormal MRI, brain MRI scans. And the most common abnormality, which was found in 33%, was dilated perivascular spaces, which is what we saw in our patient. Only 22% had cryptococcomas, and hydrocephalus is very rare. In a smaller study of 5 patients in Argentina, all 5 patients had bilateral basal ganglia hyperintensities, as was seen in our patient. And it's been shown that the radiological presentation depends on the level of immune suppression and therapy. Next. So we concluded that this patient had meningeal and parenchymal cryptococcosis, and we managed him by persisting with the antifungal treatment. So we continued on with the consolidation phase therapy and did not restart induction phase therapy. And by 10 weeks post initiation of antifungal therapy, the patient had recovered and was asymptomatic, and he recovered without any disability. So I'll now hand you over to Joe, who will summarize the evidence around HIV-associated cryptococcal meningitis.
Great. Well, thank you very much, Melanie. So for the next 10 minutes or so, I'm just going to run through a few of the points that I think we could pick up from the case that Melanie's presented, who was a fairly typical case in many ways of the patients that we see in our clinical trials of HIV-associated cryptococcal meningitis across Southern and East Africa, although not entirely typical in that he had an MRI scan, which is fairly unusual in our context, and we certainly can't get all of those lovely cytokine assays and other things that Peter was discussing in his patient. So a few of the points from the presentation I'll pick up on and discuss and show a bit of the evidence for are as follows. So the first question is, well, in the era of widespread antiretroviral therapy rollout across sub-Saharan Africa, why are we even still seeing cryptococcal meningitis, and why does it remain a common infection? I'll discuss some of the new evidence around treatment, in particular short course therapies as this patient received, and briefly highlight some of the evidence for that from the recent ACTA trial led by Tom Harrison and colleagues, also run at the site Melanie works at, and the Ambition trial, which finished and was published earlier this year. I'll touch a bit on the evidence for or what happens in terms of raised intracranial pressure in our patients, persistence of symptoms, relapse and iris, and what we saw in the Ambition study in that regard, and whether what we saw in this patient was typical. And then very briefly discuss some of the ongoing challenges we're facing in terms of ensuring that patients are able to access optimal treatment for this condition across sub-Saharan Africa. So why are patients still getting cryptococcal meningitis when we've got ART widely and generally freely available across the African continent? Well, these are some data from Botswana, where I've spent much of my time. I was based there full time for about 8 years until last year. And Botswana had one of the first antiretroviral treatment programs in Africa, and still has one of the best programs with very, very widespread antiretroviral treatment coverage. But these are the most recent UNAIDS estimates from Botswana 2020, so a year and a half ago now. And the panel on the left shows the number of people living with HIV in Botswana, and you can see that that continues to increase. And that is because we're keeping people alive with antiretroviral therapy. But if you look at the middle graph, that's the number of new HIV infections. And you can see that although there's been a significant decline in the incidence of HIV since the peak in the late 1990s, early 2000s, it still remains high. In Botswana, it's between 0.5 and 1% of the entire population acquiring HIV every year. So we haven't switched the tap off. We haven't been successful with prevention interventions. And the right-hand panel is perhaps the most depressing of these graphs. This is looking at AIDS-related deaths. And you can see that for about the last decade, that's been absolutely static. There hasn't really been a shift in the number of AIDS-related deaths. And I'll show you a bit more data as to why that may be. And I think, unsurprisingly, given that context of high numbers of people still living with HIV and these continuing high numbers of AIDS-related deaths, the numbers of cryptococcal meningitis cases we're seeing, although they've declined over time, the big thick black line is data from a study we did in Botswana, looking at the time period from 2004 to 2014. You can see that there was a decline over that time. But from about 2014, the numbers haven't declined much. The graph on the right is data from the Western Cape province in South Africa. The dots are showing the numbers of cases of cryptococcal meningitis over time. And you can see that there between 2007 and 2016, when ART was widely rolled out, as shown by those dotted lines at the bottom, the number of cases of cryptococcal meningitis didn't really budge. This graph here partly explains it. So this is in that same South African cohort, looking at the number of individuals overall with very low CD4 counts, below 50 in this case. And what you can see is that the absolute number of individuals with very low CD4 counts really hasn't budged. What has changed are the characteristics of these patients in terms of where they are in the ART program. So whereas in 2008, nearly all of these patients presenting with very advanced HIV disease were ART naive, they were presenting late to care, they hadn't started treatment. By 2017, we were seeing that most of the patients with very low CD4 counts had been in an antiretroviral treatment program, and then for whatever reason were not succeeding on therapy. They still had profound immune suppression. Either they had drug resistance, they weren't able to adhere to therapy, they were defaulting from care. So that explains, I think, in part why we're still seeing such high numbers of patients presenting with advanced HIV disease. In our context in Botswana, Melanie talked about this a bit. What's our main differential diagnosis when we see an individual coming in with a central nervous system infection? Well, these are data from a nationwide study in Botswana. These are all individuals coming through the door of a hospital, having a diagnostic lumbar puncture. And this is the breakdown of what we found. So of almost 20,000 adults having a diagnostic LP, about 41% had a clear abnormality in their cerebrospinal fluid. About 40% of those had a raised white cell count with no diagnosis. We suspect quite a lot of that is probably tuberculous meningitis or other viral meningitis that we can't diagnose given our limited diagnostic armamentarium. But if we look at what is diagnosed, you can see that cryptococcal meningitis in the blue there absolutely dominates, causing over half of all meningitis in our setting in all comers. So the HIV epidemic really has changed the spectrum of causal pathogens in terms of meningitis. And how do these patients do? Well, the outcomes are not great. These are data from relatively recent clinical trials using amphotericin B-based therapeutics across Africa, which are the best, or were until very recently, the best regimens we have data for in that context. And even in clinical trials, we were seeing about 40% of individuals dying by 10 weeks. So very, very high mortality rates. And if we looked out longer to 6 months, you'd see even higher mortality rates. And as a result of the frequency of cryptococcal meningitis and this very high mortality, it accounts for quite a large or a very large proportion of all HIV-related deaths. It's consistently found to be one of the 3 leading causes of deaths among HIV, among people living with HIV. And recent estimates suggest it causes about 19% of all HIV-related mortality. These data are from a study that was published just 3 days ago, so hot off the press, looking at the global burden of HIV-associated cryptococcal meningitis. Nilesh Govender was one of the authors on this study. They estimated, based on UNAIDS data of HIV prevalence and the number of people with advanced HIV disease, coupled with cryptococcal antigen screening data about the proportion of individuals with positive cryptococcal antigen tests on large surveys, that there are about 152,000 cases of cryptococcal meningitis and around 112,000 cryptococcal related deaths annually, a slight decline from the last global burden of disease estimates about 10 years ago, but not a very large decline. And this 19% of all age-related mortality I mentioned. So why are we seeing such high mortality rates? Well, in large part, it's because the treatment that many of these patients can access is very inadequate. Across much of Africa, people have until very recently, and in fact in many places still are, treated with fluconazole monotherapy, which carries a mortality rate of upwards of 60 to 70% acutely and even higher at 1 year. really inadequate treatment. And the use of amphotericin B deoxycholate, which was the amphotericin B formulation most widely used, or still is the formulation most widely used, was somewhat limited by the fact that it's a very toxic and difficult drug to give, particularly in resource-limited settings. So the deoxycholate of amphotericin can cause a severe thrombophlebitis. It can cause nosocomial sepsis due to drip site infections. We see it in up to 15% of our patients. It can cause severe infusion reactions, quite profound anemia, an average drop of 2.3 grams per deciliter over 14 days of amphotericin B deoxycholate treatment, which in a patient population who are often presenting with very low hemoglobin to begin with, probably carries a significant, a significant mortality risk, actually. It can cause renal impairment. We see a doubling of creatinine in quite a proportion of patients, and a profound potassium and magnesium wasting. So in order to improve care for patients across sub-Saharan Africa, there was an urgent need to define new treatment regimens that were appropriate for use in low resource settings. And one possible way of doing this was to try and use amphotericin B deoxycholate, but give much shorter courses. So there was some animal model data, these are from a rabbit model, suggesting that actually instead of daily dosing with amphotericin B deoxycholate, you could give abbreviated courses of perhaps just a 3-day course and achieve much the same outcome as with a 14-day course. So the panels on the right show the CSF burden in rabbits with daily dosing in the top panel, or just 3 abbreviated doses in the middle panel. You can see that they're very similar. And when these rabbits were euthanized at the end of the experiment, the fungal burdens in the brains of those who received daily dosing compared to just 3 doses were very similar. So proof of concept that this could work. We also had some initial phase 2 data from human studies. And Tom Harrison and colleague Sheila Malloy led this in the ACTA trial, looked at this. So the primary comparison, the ACTA trial was a large randomized controlled trial carried out across multiple sites across sub-Saharan Africa. And it was actually a relatively complex trial because it was comparing, first of all, 1 week of amphotericin B deoxycholate with 2 weeks of amphotericin B deoxycholate. Could we reduce the duration of that amphotericin B deoxycholate component, maintaining efficacy? But also it compared the second agents, so fluconazole versus flucytosine. So you ended up with 4 arms, a 1 week amphotericin B with either fluconazole or flucytosine, or a 2 week amphotericin B regimen with fluconazole or flucytosine. And there was also a 5th oral arm looking at oral fluconazole or flucytosine. Now I've highlighted the key results here in the red boxes. And this is that the lowest mortality of any of the regimens in this trial were seen with 1 week of amphotericin B plus flucytosine, 24% mortality at 10 weeks, significantly lower than that 40% that had been seen in prior studies of amphotericin B-based treatment across Africa. And in fact, in the 2 week amphotericin B arm plus flucytosine, you can see there almost 40% mortality. So by reducing the duration of amphotericin B therapy, it looked like we were maintaining efficacy while avoiding a lot of the toxicity and side effects, and in fact, reducing mortality. A key thing to note from this study is if you look to the left of that 1 week amphotericin B plus flucytosine box to the 1 week amphotericin B plus fluconazole, you see very high mortality. So what that is showing is that if you're going to give an abbreviated course of amphotericin B deoxycholate, it's absolutely critical that it's given with a highly fungicidal partner drug like flucytosine. If you try and give it with fluconazole, it's simply not enough, and you see very high mortality rates. So in that question Melanie posed in the poll, most of you got this right and selected either that 1 week arm or what I'll talk about next. So this trial led to the World Health Organization updating their guidance for treatment in low and middle income settings to suggest 1 week courses of amphotericin B deoxycholate plus flucytosine, followed by high-dose fluconazole for a week as their preferred induction treatment, avoiding many of those toxicities of the amphotericin B, but maintaining efficacy. However, 1 week courses of amphotericin B is still associated with side effects and toxicities and can be quite difficult to administer in many settings. And most of the time in Europe or America, we wouldn't use amphotericin B deoxycholate at all. We'd use the liposomal formulation of amphotericin B. So liposomal amphotericin B is known to be a much less toxic formulation. It can be given in much higher doses. As a result, it has very good tissue penetration. And we know that it penetrates the CSF very well with a long tissue half-life. And we had phase 2 study data showing that we could give a very short course, a very high dose short course of this drug and achieve the same rates of fungal clearance as with standard daily dosing. So these evidence, or these data, plus the data from the ACTA trial showing that flucytosine was an essential component of these treatment regimens, laid the background for our AMBITION clinical trial. So the AMBITION trial was a phase 3 clinical trial. We recruited patients at partner sites across, sorry, let me just move the chat out of there. Across Uganda, Malawi, Zimbabwe, Botswana, and South Africa. And we were comparing 2 treatment regimens. One was a single high dose of liposomal amphotericin B, given with oral flucytosine and oral fluconazole for 2 weeks, taking the data from our phase 2 AMBITION trial showing that you got good fungal clearance with a single very high dose of liposomal amphotericin B, and the ACTA data suggesting that that oral combination of fluconazole and flucytosine led to the best fungal clearance you could get with an oral regimen. And we compared that to the World Health Organization updated standard based on the ACTA trial of 1 week of amphotericin B deoxycholate plus flucytosine followed by fluconazole. The primary outcome was all-cause mortality at 10 weeks, and this was a non-inferiority trial, as we just hoped to show that the easier to give single-dose liposomal amphotericin B-based regimen would be as good as the 1 week amphotericin B deoxycholate-based regimen. Secondary outcomes are listed there. And these are the headline results. So overall, we ended up with 844 patients in the trial, 407 patients per arm in the intention to treat analysis. And the 10-week mortality was 24.8% in the single-dose liposomal amphotericin B arm versus 28.7% in the control arm. And our non-inferiority graphs are shown in the panel on the left there. And you can clearly see that we met our non-inferiority criteria easily in both adjusted and unadjusted analysis. In fact, in the adjusted analysis, there was a suggestion that the single-dose liposomal amphotericin B-based regimen may in fact be marginally superior to the amphotericin B deoxycholate-based regimen. In addition to being highly effective, the single-dose liposomal amphotericin B-based regimen also caused significantly fewer adverse events. And this was in large part driven by a reduction in severe anemia. So we saw 40% of patients developing severe anemia with 1 week of amphotericin B deoxycholate versus only 13% in the liposomal amphotericin B arm. So a major toxicity benefit there. Very briefly, from our case, or the case Melanie presented, I wanted to touch on 2 things. So one was raised intracranial pressure. You'll remember that the patient presented, had normal pressure at baseline, but subsequently did develop raised opening pressure. And these are the data from the AMBITION trial in this regard. So about 40% of individuals had raised opening pressure at baseline, but an additional 14% did develop raised opening pressure during the 2 weeks of induction phase therapy, having had normal pressure at baseline. So this is a very common problem, and effective management of this with therapeutic lumbar punctures is a key part of managing cryptococcal meningitis. The second issue is relapse. So I think a valid concern with giving much shorter courses of induction phase therapy with amphotericin based products is that people may relapse. And in a case like the one Melanie presented, where they had ongoing symptoms, you could see why individuals may be concerned about that. But actually, we had no culture positive relapse cases at all in the liposomal amphotericin B arm of the trial, and just a single culture positive relapse in the control arm of the trial. So actually, I think the data in that regard are very reassuring. And in terms of iris, was there an element of unmasking iris in this case? Well, possibly, but we hardly see any paradoxical iris now in our patients using highly fungicidal induction regimens and delaying ART until 4 to 6 weeks after antifungal initiation. So iris is much less of a problem than it previously had been. And we certainly wouldn't routinely start steroids in patients until we've ruled out all other avenues, although sometimes it is used for iris in people who were sure are culture negative and not responding to other therapies, but it shouldn't be used in induction phase treatment, given results from the CryptoDex trial showing that it's actually detrimental in the context of HIV associated Cryptococcus. Very briefly, just to finish off in the last few minutes, this trial was really well received by the community of both patients and doctors alike. These are some press releases. This is one from MSF making the point that for this to have any impact, we need to ensure that there's access to liposomal amphotericin across the region. And at the moment, there are very, very few African countries where this can actually be accessed. And also we need to ensure that it's affordable and that there's access pricing. Gilead, the company that make it, have put out some very positive statements suggesting that they will sell it at a not-for-profit pricing for this indication in Africa. But we certainly need to keep the pressure up and make sure that access is guaranteed. The World Health Organization have just updated their guidance to include the ambition regimen of a single high-dose liposomal amphotericin B as their preferred recommendation for treatment of cryptococcal meningitis. So I was glad to see that at least 20% of you are already choosing that as your preferred induction regimen. And just to finish, we still have major challenges. This is a roadmap for ending cryptococcal deaths by 2030. And one of the key things we need to work on is ensuring that, having got this trial data and shown what is possible, that we actually ensure patients across the region have access to treatment. These are some activists at the recent AIDS conference in Montreal making the point that ending cryptococcal meningitis deaths is an absolutely key part of ending AIDS deaths by 2030, which is the stated UN AIDS strategy. So we need to keep up the pressure and now ensure that patients can actually access these treatments that we've shown work in the trials. So I'll stop there. Of course, many people to thank. I'd particularly like to thank Tom Harrison and David Lawrence, who Tom was my co-PI on the Ambition study, David the lead clinician, and all of the study doctors at the sites, Melanie from Blantyre, and many others from across the other sites in Africa. So thank you very much, and well, back to the chairs for questions.
Thank you very much, Joe and Melanie. Thank you for stop sharing. So I think we'll get started with some questions. If Peter and Didier, there they are. Excellent, thanks. So there's several questions in the chat box. Let's get started with some questions for both cases. One specific question was, how frequently would it be recommended to repeat lumbar punctures in both HIV negative and HIV positive patients with cryptomeningitis? And of course, the reasons would be slightly different. So assuming the patient was asymptomatic. So Peter, do you want to start with HIV negative patients?
Yeah, so yeah, it entirely depends on what you're doing. The nice thing, I think, for both of us is amphotericin is a really good regimen. If we were with Cryptococcus, if we were dealing with other fungi like cocci and aspergillus, those are really difficult to do and you can't play around much with them. Cryptococcus is really different, and when you have a cidal regimen like that, it really gets the undetectable fungal loads. You can do a lot more than we can. I want to say that even with all our immunosuppressants, we've treated with steroids, we've treated 50 patients that are previously healthy, about 20 transplants, liver, spleen, even some stem cell transplants with graft versus host disease on really potent immunosuppressants. It was CD40 ligand mutations. We have idiopathic CD4 lymphopenia who get pierced. We have never had a recurrence of Cryptococcus in the CSF. We started doing a lot of lumbar punctures. We always do one, the standard 2 weeks. We do a lot more because we're doing a lot of flow and cytometry and stuff. I think once patients get a little far out, a few months, then blood cryptococcal antigen and the MRI, I can't emphasize enough the need to get post-contrast flare images. I think you'll be amazed what you can see as far as inflammation is concerned, and especially if you have anatomic localization. And so we've been decreasing the amount of LPs as we get more comfortable with this. But I would encourage, people to we usually see our patients every month or two. We've been seeing them every 2 months on these tapers and texting them at 1 month and tapering them based on that, and then based on the MRI. You don't need a lot of sophisticated testing. I think the cell count in the MRI and a cryptococcal antigen in the CSF or blood is plenty to do. We do a lot more sophisticated testing now, mostly so we can characterize the disease and I think convince ourselves. But we've treated patients in Honduras and in Africa, places that haven't had as much ability. And once your fungal cultures are negative, and of course you keep them on fluconazole for up to a year or two, usually until we have them off steroids, you just don't get recurrences. And we even had a resident who forgot to put a patient on fluconazole with a cryptococcal serum of 1 to 30,000 and came back on methotrexate and prednisone, and the antigen had come down to 1 to 8,000. We thought he'd killed her, but she ended up doing fine. So I think this is a salvage regimen, though. So you're not putting everybody on these steroids, just people who decline. And that 30% who are dying of cryptococcal meningitis, I think in the non-HIV patients, the vast majority of these are inflammatory.
Thanks, Peter. Melanie, Joe, do you want to discuss the lumbar punctures required during the induction phase, I suppose, for HIV seropositive patients?
Yeah. Thanks, Nilesh. So I understand that we're considering that the patient is asymptomatic. So if the patient is asymptomatic, you only do daily lumbar punctures if they have a CSF opening pressure of more than 30. And this would require therapeutic lumbar punctures regardless of whether they're symptomatic or not. However, we do not routinely carry out serial lumbar punctures to monitor CSF parameters or fungal clearance in the routine setting, only if you're concerned about maybe a treatment failure or a relapse, would you then repeat the lumbar punctures, but it is not done in routine. In case you're wondering about this patient, why they had a day 14 CSF quantitative fungal culture, it's because early fungicidal activity was a secondary endpoint in this trial, and therefore we did serial lumbar punctures to monitor their fungal clearance.
And while you're on that point, Melanie, could you just answer another question? What's the average fungal quantitative? What's the load at the beginning of treatment, roughly? Joe or Melanie, do you remember across your trial?
I can't remember the exact number, Nilesh, but it's usually in the the hundreds of thousands range. The tens to hundreds of thousands range is our usual starting point. Millions is high, it does happen. So the high hundreds of thousands, like this case, to millions, that's a very high fungal burden. That's the upper end of the range. The low hundreds, high tens is kind of a normal starting point, and the thousands to hundreds is a lowish fungal burden to be starting with. So this patient had a high fungal burden, even by our standards, which is that most patients have a relatively high fungal burden in the context of profound immune suppression with very low CD4 counts.
Just to follow up, those 14% of patients who have normal baseline pressures, but then develop elevated pressures during treatment, are they usually symptomatic? Is that what prompts the repeat lumbar puncture? Or did you pick that up just because you've got, in your trials, you had protocolized lumbar punctures?
Yeah, so that's a good question, Nilesh, and I can't answer that specifically. Now, my gut feeling is that most of those would be symptomatic. They would have presented with a worsening headache or worsening obtundation, which would have prompted a lumbar puncture to investigate whether they had raised opening pressure. However, in our studies, it was relatively light touch and ambition, the phase 3 study. We just had a protocolized LP at day 7 and then day 14. So some of them may have been picked up on that day 7 or day 14 protocolized LP, but most of them would have been, I think, symptomatic.
Yeah.
Thank you. Do you want to flag any of the other questions?
I think there is an interesting one, Nilesh, in the Q&A chat about the possibility to extrapolate the studies done in HIV patients for cryptococcal meningitis to non-HIV patients, and especially the last study, the Ambition trial, the single-dose liposomal amphotericin B. Can we also use that in non-HIV? And I would be very keen to hear both Joe and Peter's opinion about that.
Yeah. So this, of course, whenever we present the Ambition results to an audience in Europe or the States, we get the same question. Now, I think I'm going to slightly expand your question, Adelia. I think the question is, if we can expand this to people living with HIV, then I think the answer is yes. I think there's no reason to think that the pathophysiology of HIV-associated cryptococcal meningitis is fundamentally different in Europe or America to in Africa. And we've shown that we get very good fungal clearance with this single dose regimen, as good as with 14 days of liposomal amphotericin B. We've shown that we see very little relapse with this regimen, so we're clearly getting excellent fungicidal activity in the longer term, and we've shown good outcomes. So I would have no qualms really recommending this in the context of HIV in any setting. And I think the benefits of a shortened treatment course and reduced toxicity will be universal. However, I would be very, very reluctant to extrapolate this to the context of people living, people without HIV, because as Peter's shown very nicely in his talk, and we didn't discuss the immunology at all in ours, sorry, it was a different focus, but if we had, what you would see is that the immunology is almost entirely different. What we're seeing in our patients is an absolute lack of any decent inflammatory response. We're seeing a very high fungal burden, as we've just discussed, with a very poor C-inflammatory response. And we've seen that if you have increased levels of interferon gamma or other pro-inflammatory cytokines or classical macrophage activation markers, you have better outcomes. And we know in our context, if you give steroids, you have worse outcomes. So the pathophysiology of disease is very different. The organism burdens are very different. And I don't think that without some sort of controlled data or trial data, we could extrapolate to the HIV negative population. Anyway, Peter, I'd be interested in your thoughts.
You and me.
Yeah, so the recommendation we haven't played with on that side because we're giving so much immunosuppression. The recommendations are 4 to 6 weeks of therapy with non-HIV, which is longer than the 2 weeks for HIV. To be honest, I have a feeling, and I can't prove this, that that was because a lot of these people were having inflammatory responses, and they're routinely misinterpreted as a microbiologic failure. And we've had people on their 4th or 5th dose of amphotericin, 4th course of amphotericin, going into renal failure, treating a dead fungus. And so I can't help thinking that they don't really need anything different than the HIVs. You would think, if anything, the immune system is a little better and a little too good. So you would think that. I've been reluctant to hit both sides of the equation at the same time because, as I said, we have not had any relapses. So we typically do 4 weeks still of liposomal, but if they have any real toxicity, we don't mind stopping them a week early, and we've not had any problems with that. We've even started the steroids when the patient had 1 or 2 positive colonies and not really had much of a problem. So I'm on board with that, but I can't offer any proof that. And if you're going to give them steroids, I really can't give you any proof, but it's a great regimen.
Thanks.
If you have toxicity, I think if you have toxicity, I think it does make you feel better about stopping things after you've gotten a week of liposomal, even though it may not be at 10 milligrams per kilogram.
To change tack a little, there's a question about children with cryptococcosis. Peter, to you, just asking about HIV negative children with this post-infectious inflammatory response syndrome. Have you seen any cases?
No, we don't. We have not been recruiting pediatrics. It's really, well, I shouldn't say that. We've done a few by emails, but very few. It's not typically a pediatric disease. We have had like 1 or 2, and they've responded pretty well. Of course, ampho is not toxic at all in young children. I think our youngest that we really treated here was 17 years old. And she behaved the same way as an adult did. Her biggest problem was, the kids are going to tease me because I have a facial droop.
And Adelia, do you want to comment on the HIV-infected children?
You mean HIV-infected children with invasive crypto disease or cryptococcal meningitis? I think Joe showed the nice data from Botswana, where there's much less cryptococcal meningitis amongst children than amongst adults. And I think that's a question that a lot of pediatricians are still puzzled about, and also cryptococcal researchers. Why is that? Is that exposure, or is that a different immune response? I mean, it's comparable to a lot of infections we are seeing as pediatricians. Look at the whole COVID pandemic and the different disease manifestations with that. So there are a lot of examples. I don't know what it is with cryptococcal meningitis being of low prevalence in children with HIV. Do we not pick it up? Or has it something to do with, in general, younger children have relatively higher CD4 counts? Very happy to hear Joe as well about his opinion on this.
Yeah, well, I mean, Nilesh has some data on this as well, Julia. When in our study in Botswana, when we actually broke this down by age group and HIV status and looked at incidence, the incidence of Cryptococcus in the adolescent population, particularly when you stratify by CD4 count, similar to adults. Now in kids, it was different, undoubtedly. There was a bit of a peak in the very young kids, actually, the immediately post-neonatal group, but then it dropped down in that kind of childhood pre-adolescent group. The reasons I can't really explain. I mean, it may just be something to do with their level of functional immune suppression. It may be an exposure issue. I don't know the answer. I mean, in a context like Botswana, where we have such a high HIV prevalence, and before the mother-to-child transmission PMTCT programs were good, we did see cryptococcal meningitis in kids. Not masses, but it was actually the leading cause of meningitis. That's changed, of course, with very effective PMTCT, just because we don't see much HIV in kids in that context. But I don't know the answer, no.
So Joe, as you pointed out, we've got some data from South Africa showing similar incidents, bimodal sort of incidents in children. The WHO does recommend cryptoantigen screening in adolescents and children aged 10 plus. So, and certainly in our cryptoantigen screening program in South Africa, we've seen, the number needed to screen to find the case is fairly similar in adolescents compared to adults. So I think, children and adolescents may be slightly different. Adolescents possibly, more similar to adults. Joe, maybe we can pick up on the access issues that you brought up towards the end of your talk. If you said liposomal ampho B followed by 3-5-fluoroconazole as the preferred regimen, but in many countries across the world, some of those, 3-5-fluoroconazole and liposomal ampho B in particular are not available. There was the question about, should we be trying to enhance antiretroviral treatment using sort of novel ART regimens? But can you talk about the access issues?
Yeah, so I think a lot of what we're working on now has been a bit of a pivot from clinical trials into trying to implement and operationalize this, and the access issue is an absolutely key one. So there's no doubt we have a problem. I mean, liposomal amphotericin B is just not accessible on the continent, really. Over the last couple of years, it has been made available specifically for treatment of cryptococcal meningitis through a specific access program funded by UNITAID and led by CHAI, and they've got the product into 5 kind of pilot countries. They've shown that it can be done and that it can be used effectively in those countries. But that's still a very limited program. And the cost has been a big issue. We've been trying to pin Gilead down to committing to how much it's going to cost. I think we have got there now with a cost of around $19 per vial, which is, you know, substantially cheaper than, it's almost 10 times that in the open market price. So that's a massive reduction. And we've done a big cost effectiveness analysis of the Ambition study, currently in the process of being published, showing that actually at that cost, it's quite a cost-effective regimen. It costs a little more than the conventional treatment, but given the reduction in need for toxicity monitoring, given the reduction in need for managing toxicity, given the potential reduction in the duration of hospitalization, it could actually be quite a cost-effective regimen even at that price. So if we could get it at that price, and if we could get it into countries, I think there's it will be a cost-effective regimen, but there's a lot of work to do. There is some positive news in terms of, well, both standard amphotericin B deoxycholate and flucytosine. When we started doing these trials in South Africa in 2006, 2007, most patients were still getting treated with fluconazole in South Africa. And it was the same across the rest of the continent. Over that period of time, as we showed that amphotericin B deoxycholate was much more effective treatment, there has been vastly increased access to amphotericin B deoxycholate. And there's been a lot of work going on. Nilesh has been instrumental in this, and many others, in getting flucytosine access across Africa. There are now generic manufacturers making that drug. The cost has come down considerably, and it is now available in some places, South Africa being one of them, through routine care systems. And so I think the flucytosine shows that with the right advocacy message and with a lot of work to push that, you can improve these things. So beyond saying we've got our work cut out, I'm not sure what else to say, Nilesh.
Thanks, Joe. Maybe a question for both groups, Peter and then Joe and Melanie.
Nilesh, can I just tell you that we have 2 minutes left, basically. So,
so perhaps the last question then. When do you order antifungal susceptibility testing? Is that useful? Do you use it in any way? Peter, do you want to start?
Oh, I'm kind of an outlier. Maybe I inherited from Jack Bennett, but I don't really use them. Sometimes it will scare me, but I used to use a lot of voriconazole before I felt comfortable about the inflammatory response. Now I feel much more comfortable with it. And again, we haven't had any recurrences. So I might, if someone does an MIC and Gaudiae can have higher MICs, maybe I'll use 800 of fluconazole, but I really stopped using voriconazole unless there's toxicity. And I don't routinely do MICs. I guess if I was growing the fungus again, then it would prompt me to definitely do one. But the problem is the MICs for Cryptococcus are done under glucose conditions. And as we know, the brain doesn't have any glucose and you're looking for cidal activity. So unless you have a cidal activity test, what are you testing for? And amphotericin doesn't have a concentration, it's a suspension. So I don't know what an MIC means for amphotericin. So people keep coming up with these, but I just don't see the clinical data to support it. And I haven't found it very useful in my practice, but I'm kind of an outlier on that one.
Yeah, thanks. I would second that from our situation. Amphotericin B and flucytosine, we just don't do susceptibility testing for. I can't conceive of any clinical use for that, really. Fluconazole is slightly different. When we used to use fluconazole monotherapy and then see culture positive relapse, we did use fluconazole susceptibility testing. We did used to see quite high rates of secondary fluconazole resistance, but with the highly fungicidal initial regimens now, we're not seeing that, and therefore we're not really doing that susceptibility testing clinically.
Thanks very much. Adelia, I think we can probably wrap up.
Yeah, thanks. I think I would like to thank the speakers, Joe, Peter, and Melanie. Thanks for your contributions to this MycoClinic with some excellent cases and update on the literature. Thanks for showing the different pathophysiology and clinical presentations of those diseases, depending very much on the host. And as Peter's title was, the host does matter, what is very true. So thank you so much. Thanks also to the participants for their questions. And it was a pleasure to co-chair this session with you, Nilesh.
Great.
Thank you, Adelia. Thanks to everyone.
Thanks.